everyone. Your tutor on manual therapy, Professor Oluwale Kishokunbi. I'm here today to discuss with you on the mobilization techniques we can use for the lower extremities. The joints in lower extremities include hip joints, which is acetabulo-femoral joints, the knee joints, articulations between patella and femur, and different joints in the ankle, tibiotalar, subtalar, metatarsal joints, the rest of them. So we're going to look at techniques of mobilizing them in today's presentation. Let's make a start with the hip joint. Now, hip joint is a ball and socket joint formed by the concavely shaped acetabulum and conversely shaped head of femur. So that means concave, convex, convex, concave rule could be applicable to the techniques that we are going to be discussing here. Now, what are the available glides? Like we said in our previous slide, the direction of push of the therapist determine the name of the glide. If the therapist is pushing anteriorly relevant to the body, then we'll call it anterior glide. If it's pushing posteriorly with reference to the joint, then we'll call it posterior glide. So let's start our discussion with anterior glide of the hip joint. How would anterior glide of the hip joint be carried out? Two ways. The patient will have to lie prone with proper pillow support below the head and the pectoralis region. The therapist will have to stay opposite to the joint to be moved. All right, the therapist is staying opposite to the joint to be moved. It's also possible for therapists to stay in between the knees when the patient lie prone with the hip suspended at the edge of the plinth. It's also possible, but otherwise the therapist will have to stay opposite to the joint to be moved. The proximal hand of the therapist with the hollow of the palm will rest on the head of femur, and the distal arm will hold a flexed knee in extension and a little bit of external rotation close to the body of the patient, close to the body of the therapist. Then the therapist will deliver his body weight through his shoulder, through his elbow, the palm of his hand on the head of the femur in a tick-tock manner, in an oscillatory manner. You can use 1 oscillation per second or 2 oscillation per second for 1 minute or for 30 seconds as the patient's condition dictates. All right, what do we think the patient will gain at the end of this mobilization? Now, the therapist is pushing on the convex bone anteriorly, and you know that anteriorly directed movement in the hip joint is flexion. So because of convex rule, patient is going to gain in extension and external rotation. I discussed with you in our previous class that extension always comes with external rotation, both in the hip joint and in the glenohumeral joint. Now, what about posterior glide? In posterior glide, there are 3 ways of doing that. In the first instance, if the pain is very much, okay, like subacute phase, or the pain is a bit on the eye side, patient will simply lie supine, all right? He will simply lie supine with slight flexion of the hip joint to be mobilized. That could be achieved by placing some sandbag or rows of towels beneath the knee, so we have slight flexion, not much flexion. We don't want to keep the hip in 100% extension because that's a closed pack position, and every closed pack position is not good for mobilization because of the maximum contact between bone in that position and the reduction of the joint space. So when the pain is on the high side, therapist could stand on the opposite side to the joint to be moved and place the hollow of his palm on the anterior superior iliac spine, leaning forward as shown in the diagram. Patient is lying supine, and the therapist will pull the weight through his shoulder, through his elbow, through the palm of his hand, and deliver oscillatory movement in a posteriorly directed direction on the hip joint. Tick-tock for either 60 seconds or 30 seconds, and if the patient pain is relieved or there's more movement, the whole procedure could be repeated 3 to 5 times. If the pain has subsided or pain is not much of a problem, then therapist could get the hip into more flexed position to further open the joint and even flex the hip joint with the foot on the affected side, making contact with the floor. So with fingers overlapping, therapist could put his chest, the pectorals, right on the palm and delivered a posteriorly directed glide to the hip joint in an oscillatory manner. Tick tock, tick tock, tick tock, like that, for the same duration of time that we mentioned. And by the time the patient is even getting better with less pain, the leg could be crossed to the opposite side. The leg of the patient could be crossed to the opposite side. So that will create more movement and more flexion. That will create more flexion for the hip joints and more movement for the posterior glide to take place, and the therapist can repeat the same procedure. However, I need to make mention here, if the therapist is a female and the patient is a male, this procedure might not be that tenable. What could happen is that there could be a pillow or some soft towel between the patient body and the therapist's body, or the female therapist could just resort into pushing through the thigh on to gain the posterior glide without necessarily putting a chest on the part of the body of the patient. Okay, so that's posterior glide. Then we go to lateral glide. In the lateral glide of the hip joint, the patient will be in side lying. Our patient is in side lying, and the therapist will grab the proximal thigh. From the lateral aspect, his proximal hand will pass over the proximal femur, and his distal arm will pass behind the thigh. So the two fingers are clasped and fixed at the upper part of the thigh. So with the patient holding on to a support of the plinth, then the therapist will draw the thigh close to himself in an oscillatory manner. So it can go like in an oscillatory manner towards the patient. So that will be a kind of lateral glide. And the duration of time is the same as we specified before. So with our repeated lateral glide, that lateral glide is a movement of abduction. But because of converse rule, patient is going to stand up and gain in hip ABC adduction. All right, then we still have the inferior medial glide that could take place at the hip joint. Inferior medial glide is a two-directional movement whereby the therapist apply inferior and medial. Inferior, it will push down inferiorly and rotate the thigh medially. Inferior and medial. Patients will have to be in side lying on the unaffected side with the hip and the knee of the unaffected leg flexed in order to relax the hip. And the therapist will use his distal arm to support the distal part of the thigh and the leg close to his body. The proximal arm will be positioned with the palm right on the head of femur, and therapist will deliver a two-directional movement inferiorly and medially. Inferiorly and medially. It will deliver a glide posteriorly and turn the whole thigh bone medially, and that's what the therapist will continue to do for 1 minute before assessment and repetition of the whole procedure if there is improvement. Now, what the patient stands to gain, pushing inferiorly is like ABC deduction. So considering converse rule, that will produce AB abduction. And because there's internal rotation, patient is going to gain external rotation. So this particular movement will give the patient opportunity to increase in abduction and external rotation. Okay, so that is hip inferior medial glide. Then we're going to the knee joint, where we have several other articulations. We have articulations between patella, sesamoid patella, and femur, patellofemoral joint. There is articulation between the ends of femur, medial and lateral epicondyles, articulating with tibia condyles, and tibia condyle is also split into two, medial and lateral. So we see that better on this diagram. So you can see the patella articulating with the femur, patellofemoral glide, patellofemoral articulation, and then we have the medial epicondyle of the femur articulating with the medial tibia condyle. And then we have the lateral epicondyle articulating with the lateral epicondyle of the tibia. So guys, as we are saying, there is a patellofemoral articulation to mobilize, and there's articulation between femur and tibia, between their condyles to mobilize. So we'll look at the anterior tibiofemoral glide, that is pushing tibia anteriorly while the patient is in prone lying, pillow support below the abdomen and the head and chest, right? So the therapist will stand close to the side to be mobilized. The distal hand will support the anterior part of the ankle as shown in the diagram, and the proximal hand of the therapist will be laid on the proximal part of the tibia, posterior part of the posterior surface of the tibia, very close to the head. So anteriorly directed glide will be delivered in a tick-tock, tick-tock, tick-tock in an oscillatory manner, in the manner that that is shown in the diagram. And you'll remember that the head of tibia itself is not convex, so it's not convex rule that will be applicable here. Instead of that, it's going to be concave rule, because the head of tibia is concave instead of being convex. And you remember what the concave rule or concave convex rule states that the glide and the movement will take place in the same direction. So this anteriorly directed movement ordinarily should produce extension, and that's exactly what the patient is going to gain, because both the glide and the movement take place in the same direction. It will increase extension, right? So that's anterior tibiofemoral glide. Then we have posterior tibiofemoral glide. In posterior tibiofemoral glide, there is a soft pillow at the back of the knee of a patient that is lying supine, just to open the joint up by placing the joint a little bit into flexion. Proximal hand of the therapist lie on the thigh to stabilize it, and the distal arm will lie on the proximal part of the tibia, right? And then a posteriorly directed glide through the shoulder, elbow, palm of the therapist will be delivered on tibia in an oscillatory manner, either 2 oscillation or 1 oscillation per second for 1 minute. And if it's improvement, the procedure will be repeated 3 to 5 times. You know that this is concave rule. Whatever we do, the direction of the glide is the direction of movement gain. So patient is going to gain flexion because of application of concave rule. Then we come to patellofemoral mobilization. Now, in carrying out patellofemoral mobilization, patients can lie supine or in half sitting position, and the pillow put under the knee to open up the knee joints into flexion, an open pack or loose pack position. And then the therapist could be in a seated position or standing position depending on the height of the plinth. Both thumbs of the patient will be on the lateral side, while the index finger will be on the medial side of the patella. Now, the glide could be carried out by the 2 thumbs pushing directly to the index finger, while the index finger will return the glide back to the thumb. So it comes mediolaterally like that. All right, mediolateral glide will take place like that. Or the thumb and the index finger the thumb and the index finger of the distal hand could push superiorly, while the thumb and the index finger of the proximal hand will return the push down inferiorly. So we can have superior inferior glide like that for about 30 seconds or 1 minute. And we could also have a rotatory glide whereby the thumb of proximal hand push down and the index finger of the distal hand push upward in order to gain some rotation of the scapula. Some school of thought says that upward glide produces more flexion, while downward glide produces more of extension. But what is generally known is that patellofemoral glide generally increases the mobility of the knee joints and the patellofemoral joints. Okay. Okay, so we are now going to ankle and foot. What are the mobilization techniques? Before we go there, let's do a little bit of surface anatomy of the ankle and foot. Right, on the side of the thumb we have the tibia. On the side of the little finger we have, on the side of the thumb we have the tibia. On the side of the little finger we have the fibula. The bony protrusion On the lateral side of the ankle is lateral malleolus. On the medial side is medial malleolus. Now, below the tibia directly, there is a talus bone, a big bone here called talus bone, one of the tarsal bone. And there's another big tarsal bone on our heel that we stand on, that is calcaneus. So there is a joint between talus and tibia, tibiotalar joint or talocrural joint. And there's another joint between talus and calcaneus called subtalar joint, all right, that we need to move. Of course, there's also metatarsal joints. There's also need to move the metatarsals and the phalanges. We'll discuss that in a short while. Now, this is exactly what I'm talking about. This is talus bone at the end of tibia, and this calcaneus bone, that's the bone that will stand on. So the joint between talus and tibia is talocrural joint or tibiotalar joint, and the joint between talus and calcaneus is subtalar joint. This is mid-tarsal joint here. So how exactly do we achieve mobilization of this joint? Now, before we move to the ankle joints, it's always a good practice to open up from inferior tibiofibular joint before we move into the ankle joint, just like we discussed when we are talking about the wrist joints in the upper extremities. So we start off with inferior tibiofibular glide before we now go to those tarsals, metatarsals. How do we carry out the inferior tibiofibular glide? Patient will be in prone position, and the front of the ankle or the distal part of the leg will be supported with pillow or soft cushions. And the therapist will use the space between his tena and hypotena eminence, one place on tibia, one place on fibula, and he will stand in a walk standing position, so he can transmit his body weight through his elbow, through his shoulder, elbow, and wrist to push both tibia and fibula anteriorly simultaneously. Or he could choose to stabilize the fibula while he'll be using one of his upper extremity to move the tibia, and after finishing with tibia, he will stabilize the tibia and he will use the other extremity to move the fibula. All right, generally this inferior tibiofibular glide is good to increase general mobility of the ankle joint. So after this is done, 1 to 3 repetitions or 1 to 5 repetitions, then we can move to the ankle joint proper. In the ankle joint proper, the first joint excuse me, the first joint we want to mobilize is the tibiotalar joint or the talocrural joint, and it can be glided anteriorly and posteriorly. To gain the anterior glide, we cannot access talus directly. We have to push talus via pushing calcaneus. So anterior glide is carried out by having the patient lie down in prone position with proper roll of towel or bandage in front of the ankle, and the therapist will put his hand on the calcaneum. It's not actually the calcaneum we have in mind, it's the talus we have in mind, but we cannot reach the talus directly. So the therapist will use the hollow of the space between tena and hypotena eminence to push calcaneus downwardly, and that will result into anterior displacement of the talus, and it will go in that oscillatory manner, up, down, 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 tick tock, tick tock. It will go like that. And you know, anteriorly directed movement in the ankle joint is dorsiflexion, but because the talus bone itself is convex, it's a convex shape, so convex rule is going to be applicable here. Even though anteriorly directed movement should be dorsiflexion, at the end of this maneuver, patient is going to increase in plantar flexion because of the convex rule. All right, and the posterior tibiotalar glide or talocrural glide, therapist can be in a seated position, and patient can also be in a seated or supine position, properly holding the edges of the plinth, and the therapist will clasp his hand to the front of the foot with the finger interlocking, and then he will draw the foot closer to himself in an oscillatory manner. That movement will move the talus down in a posteriorly directed effort. So the talus will be moving posteriorly. So that oscillatory movement can go tick tock, tick tock, tick tock for 1 minute. And you know, posteriorly directed movement in the ankle joints by anatomy is supposed to be plantar flexion, but because the talus is convex in shape, that's going to result into what? Into dorsiflexion. So posterior glide of the ankle will produce increase in dorsiflexion. All right. Then we now move to the joint between talus and calcaneus. If you like, you can call it talocalcaneal joint, but it's also called subtalar joint. That joint is particularly responsible for the movement of inversion and eversion. So any mobilization that we carry out in that joint will eventually result into inversion and eversion. So how do we move this joint, guys? Right, patient can be in supine lying position or half sitting position, holding on to the support of the plinth. Therapist will grab the heel bone with the cup of the hand, with the hollow of the hand. He will grab it firmly and move it clockwise and return anti-clockwise. Move it up clockwise. It will move it up clockwise or anti-clockwise. It will move it up anti-clockwise and return it down clockwise. Move it up anti-clockwise and return it down clockwise. That will be the phase of the movement, the type of movement that will be carried out for about 1 minute. If reassessment is carried out, patient feels better, and there is an increase in inversion and eversion, the whole procedure can be repeated 3 to 5 times. That's for subtalar joint. Then we move to the mid-tarsal joint or the intermetatarsal joint. How is mobilization of that joint achievable? Well, what has to be done? Patient can be in lying position with the ankle at the edge of the plinth, and the therapist will sit on the inside of the foot. He will sit facing the inside of the foot that is about to be mobilized. The proximal hand of the therapist will be on the ankle joint with the fingers pointing away from the therapist, and the distal arm will be on the foot with the fingers pointing towards the therapist. Now, the way to remember the desired movement in this joint is what we call dorsal distal media. Dorsal distal media. Dorsal distal media. The dorsal implies that patient will lie supine. That's what the dorsal implies. Distal means that after everything is being said and done and patient is lying supine, therapist will apply a distal traction and then rotate the foot medially. So the mobilization is carried out in form of poop, poop, tick, tock. It's a two-directional movement as well, distally and medially. It will move distally and turn the foot medially. And by so doing, it will be able to affect mobilization of the mid-tarsal joint. Now, this movement is particularly good to increase mobility as far as plantar inversion and eversion is concerned. I hope that is very clear. And for the metatarsal, the same way we mobilize the metatarsal in the upper extremities, what we do, the two hands, the therapist will count the 5 metatarsals, and then the proximal hand will be on one metatarsal, while the distal hand will stabilize the rest of the 4 metatarsal. So with the proximal hand, the therapist can glide the first metatarsal up and down, up and down, up and down, up and down for 1 minute or 30 seconds and repeated 3 to 5 times. When it's done with the first metatarsal, the proximal hand will move to hold both the first and the second metatarsal, while the distal hand will hold the rest 3 metatarsals. And the movement will now be carried out on the second metatarsal in the same way and manner that was done on the first metatarsal. And thus the movement will be repeated for the third, for the fourth, for the fifth metatarsal in the same manner. Don't forget, when this movement is carried out, it enhances again inversion and eversion. That's movement of metatarsal. And when you talk about the phalanges, there's proximal phalanges, middle phalanges, and distal phalanges. So if the movement is to be carried out, the proximal hand of the therapist will stabilize. If you want to move the proximal phalanges, the proximal hand of the therapist will stabilize the metatarsal, and the distal hand of the therapist will hold on to the proximal phalanges and will move the metatarsophalangeal joint into flexion and extension. Flexion and extension. But don't forget that flexion is good. It comes with this distraction. So the therapist will apply a distraction, a traction before going into full flexion. And when extension is reached, it will apply a little overpressure as Flexion comes with distraction, extension comes with a little bit of overpressure. So we'll carry that out for the on the metatarsophalange joint by stabilizing the metatarsals and move the first phalanx. Going to the middle phalanx, proximal hand will stabilize the proximal phalanx, and distal hand will be on the middle phalanx and repeat the movement of flexion and extension. Then going to the distal phalanx, proximal hand will stabilize the middle phalanx, and distal hand will move the distal phalanx in flexion and extension using distraction and approximation or compression, as we have just mentioned. The same way, the movement will be carried out on all the phalanges of the foot. And that, in a way, in a nutshell, is the way the foot and ankles will be mobilized. That is all for now. Don't forget, you can get a copy of this on my YouTube channel as well. And that link is what we have here, but I'm going to remove this link now. This one is having some audio problem. But as it were, on the you're gonna get a new link here whereby you can feature into my YouTube channel and watch the video over repeatedly again if you so desired. Thank you very much, and thank you for listening to this. Until we meet at another time, it's me, your tutor, Professor Oluwaleke Shokunbi, Professor of Manual Therapy, Orthopedic and Musculoskeletal Physiotherapy. Have a nice day. Thank you.